Good evening, everybody, and it's my pleasure on behalf of the EAUN Continent Special Interest Group to welcome you all to this Zoom on pelvic organ prolapse and the impact on urinary function. It's really lovely to see so many of you here today, and I know people are attending from all over the world, from Australia to America and all over Europe. We know that many of our patients suffer from incontinence as a result of prolapses, and there are many out there, preventative, medical, surgical, whatever. And this evening, we're going to actually listen to some of the experts talking to us. Just moving on to my next slide, which is moving. My name is Eva Wallace, and I just wanted to let you know that I have no conflict of interest. This is our programme for today, and I'm delighted to say we have some excellent speakers here with us, and I will introduce them as they are in their turn. The first person that we have up really is Dr. Margherita Alfona. Dr. Margherita works in the University of Milan in the Department of Obstetrics and Gynecology at San Paolo Teaching Hospital and specialises. So let's say hello to Margherita and welcome her, and I'll talk to you all later. Just to remind you that if you have any questions, please put them in the question section and we'll have a little chat between each of the speakers. Thank you.
Thank you, Eva. Good evening, everyone. And okay. And thank you for this opportunity, and thank you everyone for being here with us today. My name is Margherita Fonina. I am a fourth-year resident at the Department of Gynecology and Obstetrics at the University Hospital San Paolo in Milan. And today I will guide you through the consequences of pelvic organ prolapse on the pelvic floor function. So, as you probably know, the pelvic organ prolapse is a very common condition affecting for 30 to 50% of women in the Western world. The treatment of pelvic organ prolapse requires significant healthcare resources. For example, between 2005 to 2006, in the United States, $300 million were spent on it. And the treatment, the surgical treatment, was the most common procedure performed between the 1979 and the 2006 between women over 70 years old. This pathology could be asymptomatic, or it could be could bring to symptoms that could impact daily activities, sexual function, and everyday life. So know these symptoms and learn how to recognize them. It is mandatory in our profession. As to do so, it is very important to have in mind some anatomical reminders. So what are we talking about? We are talking about the pelvic floor, that it's a unique anatomical location where different pressures such as visceral pressure, muscular pressure, or liquid pressure play a fundamental role in maintaining the physiological functioning of the organs containing the urine. So we can design the pelvic floor such as a box that has like a superior border, the imaginary line between pubis and the sacral promontory. Then inferiorly, we could delimit it by the imaginary line between the ischial tuberosity and the apex of the coccyx, and finally we have the perineum below. So from an anatomical point of view, we can describe 4 regions. So we have the anterior region, or the urinary one. We have the posterior region, or the intestinal one, the medial region, or the genital one, and above all, we have the perineum. But the most important thing to remember is, of course, the functional classification that you see listed here in this slide. So we have the diagram, or pelvic floor, formed by the ischio-coccygeal muscle and the levatory ani muscles complex, the urogenital diaphragm, formed by the triangular ligament or fascia of Carcassonne, and finally the perineum, that is the continuation of the Carcassonne fascia. Moreover, there were described 3 integrated levels of vaginal support, the so-called Delancey levels. Of course, these levels are imaginary, but they are fundamental to understand the etiopathogenesis of the pelvic organ prolapse. So briefly, we have the first level that is formed by the uterosacral and the cardinal ligament complex. We have the second level formed by the arcus tendinous of the fascia pelvis. And finally, we have the third level formed by the perineal body, the perineal membrane, and the perineal muscles. A weakness or a defect of one of these levels could bring the different problems related to the pelvic organ prolapse. So, for a defect of the first level, we could have the hysterocele. For a defect of the second level, we could have the cystocele. And if we have the weakness in the anterior part of the third level, we could have the stress urinary incontinence. While if the defect is posterior, we could have the rectocele. To better classify and compare all these patients, and also to conduct clinical studies, it was introduced also the POP-Q system. That is a very complex system that we won't see in the detail today, but it's important to know that there are some different points to analyze during the visit of the patient in our outpatient clinic to could classify this patient and the stage of the prolapse of our patients from stage 0 to stage 4, and we can do it considering the grade of the prolapse from the hymenal plane. So at the stage 0, we have no prolapse, while at the 4th stage, the vagina is completely reversed. But back to our focus, to the topic of our presentation, we can talk about the dysfunction symptoms of the pelvic floor organ prolapse. And to do so, you can see here one of the most recent reports from the International Urogynecological Association that analyzed all these aspects. And in particular, it's a report that was conducted by 9 international urogynecologists and 1 medical student. And the findings of this report are summarized in this table. And we will see them one by one, starting by the urinary function. So often our patients, while coming to our clinic, are complaining about different symptoms for the urinary field, such as storage symptoms, obstructive voiding symptoms, splinting to void, and urinary incontinence, both stress urinary incontinence or urgency incontinence or mixed incontinence. And from this report, it was confirmed that the symptoms, especially the obstructive voiding symptoms and the splinting to void, are directly related to the pelvic organ prolapse, especially when the pelvic organ prolapse is at least at third degree or more. For the bowel function, we have more than 50% of patients reporting symptoms such as obstructive defecation, anal incontinence, storage symptoms, splinting to defecate, and so on. But from the results of the report that we are considering, it seems not to be a real correlation, and this symptom seems to be more coincidental than directly related to the pelvic organ prolapse. Another fundamental aspect of pelvic organ prolapse is, of course, the sexual function. Sexual function is always disturbed by the pelvic organ prolapse because of discomfort, because of not feeling confident of the woman, because of the vaginal bulge, and so on. So women often refer like dyspareunia, anorgasmia, lack of lubrication, of libido, or anorectal or urinary dysfunction during sexual intercourse. However, this is one of the most difficult aspects to investigate and to assess, such as the direct correlation between the pelvic organ prolapse, because the most of the studies reported in literature are not considering this aspect, or they are not separate the women that are sexually active from women that have not sexual activity, even without the pelvic organ prolapse. And last but not the least, the pain. Up to 50% of women with pelvic organ prolapse are reporting low back pain, pelvic pain, abdominal and generalized pain. But also in this case, a direct correlation has not been found between these symptoms and the pelvic organ prolapse. So what can we say? We can say, of course, that only for the lower urinary tract symptoms, we have a direct correlation between these symptoms and the pelvic organ prolapse, especially when the pelvic organ prolapse is advanced. But all the other symptoms that are reported by our patients are very, very important to know, to understand, and to investigate. And to do so, a lot of questionnaires were validated, and they can, of course, help us to better understand our patient and also the spectrum of the pelvic organ prolapse symptomatology. All of these questionnaires are in English, and they are often validated also in other languages. So here you can see some of them validated in Italian language. So in conclusion, what can we say? We can say that, of course, the pelvic organ prolapse is a frequent condition that can bring a huge spectrum of symptoms. Symptoms that could cause dysfunction across multiple organs, and that it's important to know what can we find in order to counsel our patients that are struggling with the decision of the treatment intervention, in order to better guarantee the best standard of care. So I would like to thank you once again And here you have all the bibliography of my presentation if you want to know more. Thank you.
Sorry, Eva, I think your microphone is muted.
Okay, I'm on mute now. Thank you for that, Stefano. I was pressing the unmute button. Sorry about that, everybody. That was excellent, Margherita. Thank you so much for such an informative talk. It really actually opens our eyes when you tell us that at least 30 to 50% of people in the Western world, female people, suffer from pelvic organ prolapse. It's actually quite a high percentage. And if we look at all the issues around it that you have discussed with us between urinary function, bowel function, sexual function, they really add up to really affecting a person's quality of life. Most informative talk. Thank you. So next, I'll just just to share the screen, everybody, really, that is just a diagrammatic thing. I just wanted to bring you back now to our second speaker. And unfortunately, Dr. Georgia Gia is unfortunately unable to be with us today. I think she must have got called to theatre or something. So she has kindly sent us her the recording on the video. So we will actually put that on now and listen to what she has to say. Her talk really is about surgical techniques for pelvic organ prolapse repair from vaginal to robotic. So thank you, Dr. Gia, for taking the time and trouble to record this session for us.
Association of Urology Nurses for this kind invitation. So pleased to be here, and thank you to the European Association of Urology Nurses for this kind invitation. So let's talk together and spot our attention about some surgical technique for the pelvic organ prolapse repair. So what actually is a prolapse? A prolapse is a descensus of the organs located into the pelvic cavity. And it can involve the uterus, the bladder in the anterior compartment, the rectum, and the small bowel in the posterior compartment. Why do we bring a patient with a prolapse into the operating theater? So it's not cancer, it's not endometriosis. Why do we have to treat it? We do have to treat it because a prolapse actually may bother the bladder function on the urinary as a urinary incontinence or as a retention. It can bother the rectum voiding as well as the sexual intercourse or anyway the everyday life of a woman. So what actually do we want to realize with our surgery? We want to restore the normal anatomy and to improve the quality of life of the women. We have two ways to do that. We can support the organs, and this is our surgery from below, or we can suspend our organs, and in this case, we have a surgery from above. So two different approaches. Starting to talk about the supporting surgery, that is the surgery from below, it is actually the vaginal route. It is the one preferred by the gynecologist, at least at the beginning of this history of surgery of the prolapse. And it consists with the duplication of the vesicovaginal fascia, or an attachment or duplication of the uterosacral ligaments, as well as an attachment of the sacrospinous ligaments. So actually it is a surgical work on the endogenous tissue. So we use what we already find into the body of the women. But this tissue is actually damaged, so it's not so strong as the beginning. So we are trying to restore and duplicate something that is anyway a little bit weak. So which are the pros of this surgery? We do not require general anesthesia, and actually it is considered to be an easy surgery. So it's not a heavy procedure, it's not a big deal. We propose our intervention to the patient as a minor surgery. On the contrary, it is a minor surgery, but we do have a demolition, as we most of the time, to perform a better correction of the pelvic plane. We do have to remove the uterus, so we have a demolition surgery. We have, in a quite high percentage of cases, dyspareunia after this kind of procedures. And anyway, we have a high percentage of relapse. That is the major problem connected to this kind of surgery. So the research and the scientific literature, together with the research of the factories, propose the introduction of the use of prosthetic tissue. So the prosthetic tissue, called also mesh, are stronger than the native tissue, and they can give less relapse, of course. At the beginning, the most used tissue was Prolene, then polypropylene, and now titanium-coated mesh. So on one hand, we really have optimal restoration of the anatomy, less relapse, but we have a higher percentage of infections, erosions, and even fistulas. So in correlation with these results, the FDA forbid actually the use of vaginal mesh. So the application of any prosthetic tissue of any mesh in the vaginal route. And in this situation, we had the beginning of the surgery from above, so the suspension, that is the abdominal approach. The abdominal approach started actually with laparotomy, and here we have the introduction in the surgery of prolapse of other specialties like urologists and general surgeons, besides gynecologists. So quick laparotomy passed into laparoscopy and later into robotic surgery. What did we acquire with this evolution? We gained the same quality of prolapse correction, of course, a faster recovery, a better sterility, that is a very important point talking with mesh, a faster procedures, and maybe we will see in the future with robotic surgery, maybe less relapse. We're still collecting many data, and the literature is working a lot about this subject. Talking about robotic surgery, we can start talking about multiple platforms. So the surgery of the correction of prolapse is performed with the traditional Da Vinci, we can now call it traditional, with the Ugo RAS system by Medtronic, and lately also with the Versus system. This kind of surgery is not supporting, but is using another criteria, another idea behind, that is to wrap and suspend the organs prolapsed. Actually, we do not work directly on the organs, but we work on the fascia connected to the organs, these organs. So, like, we wrap and suspend the vesicovaginal fascia to suspend anteriorly the uterus and the bladder. We wrap and suspend the rectovaginal fascia to suspend the rectum, and we attach the mesh to the levator ani muscles to suspend the pelvic floor. So we wrap and we suspend, but then we attach to which structure? If we attached our mesh to the promontory, we get the promontofixation. If we attached our mesh to the pectineal ligaments, we get the pectopessy. Or if we attach our mesh to the abdominal fascia bilaterally, we get a POPS, a bilateral pelvic organ prolapse suspension, according to Dubuisson. That is the gentleman who invented this technique. So what do we get with this intervention? We get a better correction of the anatomy, we get less relapse, but of course we still have a very small percentage of erosion, that is 4%, 3-4%, according to different cases, series. We may have some pain, and still we have a small percentage of relapse. So talking about pain, pain is a surgeon's problem. It comes from mainly two reasons, that is too much tension on our meshes, or the compression or entrapment of a nerve plexus that happen maybe during the suture most of the time. And the relapse, that is the second problem that we have, that is also a surgeon's problem. It comes from not enough tension that we gave to our mesh, or an insufficient dissection of the spaces. That is also a very important point. But lately, the most important complication that we can have, that are the erosions, are not only a surgeon's problem, but also a scrub nurse problem. And I want to focus on this point because it's very important. So the protocol of sterility, it's really a very high problem and a very important point to focus on. The timing of opening of the mesh is a focus for us. So we don't open the mesh before getting to the right moment when we want to use them. So we wait for that moment and we open the package just when we want to grab the mesh and put it into the abdomen of the patient. So the mesh is not hanging around, but is open and put inside directly. Before doing that, everybody is changing the gloves. So the scalp nurses, the surgeons, the assistants, everybody. And if we have to place the mesh on the table of the scrub nurse, we find a absolutely clean, sterile space. If there are any parts of the mesh, like in the Dubuisson technique, that is in communication with the peritoneal cavity, once it's placed, we do have to cover it and to protect it with a sterile tissue. So, in conclusion, we can say that to restore the anatomy of the patients is really the key principle of the POP surgery. So the correction of the organ prolapse can go for different way, for different approach. We have different ways to skin the cat. And the most important thing is to remember the sterility protocol is really the key for success. So thank you for your kind attention.
That was an excellent talk, actually, and I love her analogy between support and suspension, and the way she used the bridge. It actually gives you a great idea of what needs to be done when it comes to surgery. And I suppose when you look at all the different types of surgery they are, it's important that our patients understand the options that they have and what they can actually adhere to. I suppose next, really, I need to welcome Dr. Stefano Terrazzoli. As you all know, he's very well involved with the EAUN. He's been on every committee that there ever was there, and he was also our past president. He's just got a new job now, and he's due to change shortly, and he's going to be working with one of the universities in Milan. So congratulations to Stefano on that, and we're looking forward to hearing what you've got to say to us today on optimizing the patient's pathway to surgery, how to get optimal results and make them last. Thank you, Stefano.
Yeah, thank you very much, Eva, and good evening, everybody. I think I have a few additional minutes for this presentation, in which I would like to focus on my point of view as a rehabilitation nurse, and in this case, as a pre-habilitation nurse. The so-called pre-habilitation is an activity, it's a branch of rehabilitation aimed at doing something before surgery instead of acting after the patient has been operated. The aim of pre-habilitation is to make the patient as strong and ready from a physical point of view as possible to surgery. So that's why we are talking about optimizing the patient pathway towards surgery. So our question is, are there any evidence? Is there any evidence that tells us that we can get better results if we do something before surgery? And is there any evidence that tells us that these surgical results are going to last longer if we do something before the operation? Well, I will start by saying that I have no conflict of interest to declare. And these are my key questions and the goals of this presentation. So, we all know that the available evidence has extensively discussed pelvic floor muscle training, so the so-called exercises for the pelvic muscles. But there are several other methods described in the literature, for instance, hypopressive therapy, yoga, breathing exercises in all possible positions. This methods have also been discussed in view of surgery. So the key questions of my presentations are as follows. The first, is hypopressive therapy effective in helping patients with pelvic organ prolapse obtaining better functional outcomes after surgery? The second, do breathing exercises, yoga, and methods other than hypopressive therapy have any role in improving pelvic organ prolapse? 3, we all know that our patients very often look up on the internet searching for information, and very often they come to our outpatient clinics and show us the latest videos that they have watched on YouTube or the latest post that they have read on the social media. So the question is, how reliable are the online information sources directed to the general public, and how can we address potentially harmful misinformation leading patients to do-it-yourself practices? So let's start by saying what actually hypopressive therapy is, because this kind of therapies has gained a lot of hype over the past years, but it dates back to the 80s. It was introduced by a Belgian physiotherapist named Marcel Coffrier as a form of postural stabilization. So what is the specific principle? The principle is that a series of exercises can be performed through shallow inspirations in order to create a negative pressure, so sort of an aspiration inside the abdomen, which, according to the theory behind this technique, could help raising the pelvic organ. This is the rationale behind the curtains when we read an article suggesting hyperpressive therapy for pelvic organ prolapse correction. But the question is there any solid evidence or is it just theory? So let's take a closer look. First, when we talk about a treatment, it is appropriate to discuss the number of information sources that we have, and most of all, the quality of the available evidence. So let's begin by saying that no meta-analyses are available. So we don't have the strongest form of scientific literature for this kind of treatment. There is only one systematic review, which has been published 5 years ago and includes very few studies of good quality. If we search randomized controlled trials on PubMed, we only find 5, and they have been published between 2012 and 2023. This is an information by itself, because if in 11 years only 5 studies of good design have been published, well, this means something to me as a researcher. The most recent and I would say comprehensive publication on this topic is a non-systematic review by Kari Bo, who is a Norwegian professor of physiotherapy, and she has also collaborated with the EAUN in past years. So let's take a look at this evidence. This is the paper by Kari Bo. This is the review I was talking before. The authors carried out a literature search and narrative search on several databases. It is a very comprehensive review, although not systematic, because it includes papers from 1996 to December 2021. The authors have chosen to only include randomized controlled trials, which of course is a point of strength for this review. They also used very good combinations of keywords. So as we can see here, they didn't only consider exercise therapy or pelvic floor muscle training or hypopressive exercises, but they also included Pilates, yoga, Tai Chi, breathing techniques, and this kind of things, which are very important to us as rehabilitation nurses, because patients very often ask us information about these techniques. The review we are talking about includes 4 of the 5 RCTs I mentioned in the previous slides. So I'm going to discuss this review, the 4th and the 5th RCT separately. So let's go straight to our first question. Is hyperpressive therapy effective? Well, the literature tells us that only 2 trials had sample size calculation. This is a major point of weakness, because it means that the other papers included in this review do not allow us to determine the probability of errors in the conclusions. So there is no certain level of reliability with the studies. One of the trials included in the review only compared hyperpressive therapy with no treatment. So the authors of this paper did not consider pelvic floor muscle training. I am repeatedly mentioning pelvic floor muscle training because in the international guidelines and in the reference book published by the International Continence Society, as well as in the European guidelines of the EAU, they are mentioned as the first-line treatment for pelvic organ prolapse. So they are the reference treatment to be compared to. All the randomized trials studied 3 months treatment, except for one which proposed 2 months. There are no specific details about the positions, the number of repetitions, and the things that would allow complete repeatability of the pelvic floor muscle training schedule. And the same can be said about hyperpressive exercises. But overall, these are the results. The evidence from 4 RCTs included in the review is conflicting. However, the trials are sometimes underpowered, and this might be a reason for this conflicting evidence. Considering the quality of the RCTs, it can be concluded that hyperpressive therapy is not likely to be more effective than PFMT for managing pelvic organ prolapse. This doesn't mean that hyperpressive therapy has no role in the journey of the patient towards surgery, because there might be some specific cases in which the patient is unable to perform pelvic floor exercises, but is able to perform hypopressive exercises. This has happened to me a few months ago. So there are cases in which hyperpressive therapy might come in handy, but the overall evidence behind it on a general basis, talking about the general patient that we usually see in our consultations, is not very strong. Furthermore, an adverse effect of back pain was found in women performing hyperpressive exercises. No adverse effects were found in the groups performing pelvic floor muscle training. This has to be considered as well. Other conservative treatments have been studied by the literature. Now we can say something about yoga with a caveat. First of all, when we say yoga, we should keep in mind that yoga is a very complex activity, because there are so many schools and so many branches, Hatha Yoga, Ratna Yoga, and many more, each with specific positions which are called asana in the language of yoga practitioners. So when we say yoga, we should be very careful. So what kind of yoga with what kind of positions for how many seconds or minutes and so on. But overall, from a scientific point of view, the situation is unfortunately very simple, because the authors of the review say that there are a number of issues with the RCTs and yoga. The inclusion criteria for pelvic organ prolapse were unclear. The conventional treatment, so the control treatment, was not described, and the description of the yoga practice was equivalent to a pelvic floor muscle training program. So the so-called yoga group in the available trials, which are basically these two reported here, performed contractions 8 to 10 times for 7 minutes, twice per day for 12 weeks. Hence, we could classify this as a PFMT program because it is actually equivalent from a physical point of view. The study cannot be used as evidence for yoga as such in the treatment of pelvic organ prolapse. So based on the current evidence, individual pelvic floor muscle training is still recommended by the authors of this review. There was a fifth trial not included in the previous review. In the beginning of my presentation, I mentioned a systematic review. It basically says the exact same things that Caribou described in the paper that I've gone through in the past minutes. So I generally referred to the review as a general term, including both the systematic and the review by Caribou, which is most recent and encompasses exactly the same evidence with the same conclusions. The fifth trial was not included in Caribou's work, and it was not included in the systematic review as well, because the systematic was published in 2018, while this paper was published 2 years later. This paper has a point of strength, which is sample size calculation, which allows precise determination of the margin of errors in the conclusions. And it enrolled 3 groups of 33 women each. The first group was pelvic floor muscle training, the second hyperpressive exercises, the third a combination of the previous 2 groups. All programs included the same educational components and instruction about lifestyle intervention and the neck maneuver, which is something particular. The neck maneuver is a sudden increase in the abdominal pressure, and is something that has not been studied in other papers. So I encourage you, if you're interested in this topic, to read this trial, to go through this trial, because the intervention is kind of particular. What are the results of the study? Here we can see the diagrams regarding objective changes. Also, subjective symptom scores have been used by the authors, so this is a very interesting paper. They also studied the changes in manometry between the visits in dynamometry of the pelvic floor and the basal tone. The three colors represent the pelvic floor muscle training group, the hyperpressive group, and the combination group, as you can see. And these are the results. Overall, women reduced their symptoms on the pelvic floor distress inventory. They improved their quality of life. They improved their pelvic floor muscle strength, objectively measured by manometry and dynamometry, and they increased pelvic floor basal tone, which is very important for pelvic organ prolapse, and is a major goal towards surgery, because from a physiological rationale, there might be a relationship between the tone that the pelvic floor obtains before surgery and the duration of the surgical outcomes. This is the concept of optimization. Individual PFMT, the authors also say, hyperpressive exercises and a combination of both interventions significantly reduce pelvic floor symptoms, enhance quality of life, and improve pelvic muscle strength and basal tone, both in the short and longer term. This is a study that, in my opinion, deserves a careful consideration, also in view of personalized pre-habilitation pathways towards surgery of our patients. The second question was are other conservative treatments effective? We already went through the evidence regarding yoga. There is something more to be said. The only available randomized clinical trial on breathing in inverse position and hip exercises, which is something very particular, not common in literature, compared this kind of treatment to pelvic floor muscle training. This was also discussed in the review by Caribou and colleagues, and the authors concluded that the authors of the review concluded that it is difficult to see the rationale for why exercises for hip abduction, and external rotation and breathing should have any effect on pelvic organ prolapse. Except for a possible co-contraction of the pelvic floor muscles. However, this study by Kruger and colleagues published in 2019 has shown that these co-contractions have minimal effects. So actually, the authors of the review discourage the practitioners from suggesting the patients to perform breathing in inverse position and hip exercises, because there is no solid rationale behind this for pelvic organ prolapse. So the final answer to questions number 1 and number 2 is that to date there is a 1A level recommendation, which is the strongest possible recommendation for pelvic floor muscle training as the first-line treatment for prolapse. No adverse effects have ever been reported in any studies regarding pelvic floor muscle training. The results from the randomized trials on the effects of other exercise programs are not convincing, as the studies are biased in terms of both methodological and interventional factors. So we shall stick to pelvic floor muscle exercises. These are the papers and books by the International Continence Society supporting this 1A level recommendation. Any further considerations in our pathway towards surgery? Oh, yes, there is a study published in the 2018 by the Cochrane Library. It is a systematic review and meta-analysis. This doesn't add any evidence regarding hyperpressive therapy, because only one of the RCTs already mentioned was included. The main conclusions of the Cochrane group was that the simplest of the pelvic floor muscle programs required women to attend 6 perioperative consultations. This was about perioperative, so some of the consultations and the exercise sessions were performed before surgery, and the remaining sessions after surgery. The results of the clinical trials provided no clear evidence of a difference between groups in objective failure at end sites at 12 to 24 months. So this still supports pelvic floor muscle training over other treatments. Also, there were no consistent findings regarding the awareness of women with their prolapse. The RCTs were often small in sample size, and there was no clear differences between groups at 24-month follow-up in rates of repeat surgery for prolapse. The authors also compared other conservative treatments such as other interventions other than surgery such as pessary, but the overall message is that we should still stick to a pelvic floor muscle training before surgery for optimization. Our final question: our patients often search the internet for information, but what do they exactly find? This is a very interesting study published on neurourology and urodynamics a couple of years ago, and it says that low to moderate quality was present in 74%, which is 3/4 of the posts analyzed on various social media, including YouTube, Instagram, Pinterest. The most common publisher content was health and wellness or physical therapy groups. The most common YouTube publisher was doctors, hospitals, or clinics. Pelvic floor muscle training was the most discussed treatment, and on YouTube, surgery was discussed more frequently than Instagram or Pinterest. Social media content is most commonly aimed at discussion of treatment options, which is something that should be done with a healthcare professional, not on a do-it-yourself basis. While only 16% of the posts discussed the anatomic etiology of this condition, which is of paramount importance to our patients to understand their condition. YouTube, which is probably the most common source of information, has the poorest understandability, lowest quality, and highest level of misinformation. The bad news is that at least 1/5 of our patients with prolapse are already on YouTube, and a majority of patients have used or would like to use social media to learn about POP. So the conclusions is that evidence about hyperpressive therapy is conflicting and often comes from low-quality studies. Evidence about other treatments, yoga and other interventions, is often biased. Pelvic floor muscle training remains the most studied treatment. It is safe, effective, and has better quality evidence. However, I'm not saying that the other treatments are useless or harmful, because there is no evidence about this, and assessment of specific cases is always encouraged. Finally, reliability of online information is often very, very poor. This is an opportunity for healthcare providers to direct patients to curated lists of high-quality educational content on these platforms, and scientific societies such as the EAUN have a pivotal role in this potential activity. Thank you for your attention.
Stefano, thank you very much. That was excellent. It really leaves a lot of food for thought, doesn't it, when you look at what is available out there and the information that is available. It really leaves us as nurses that we really must make sure that our patients get the best possible information going that we can give them. And I suppose when you think of patients, an awful lot of it is down to personal choice. You know, what is your main problem? How bad is it? So I would think before you start down any of these routes, it would all be about assessment and what actually is the patient, you know, what is acceptable to them. What is acceptable to one patient isn't acceptable to another. So it's so important for us to actually see that. I didn't see any questions coming in from our audience. So please, can I just remind you, if you have any questions, we'd be more than happy to answer them. So please send them in to us. I'm just trying to think. Margarita, I had a question for you, if that's okay.
Yes,
and I was just wondering, when your patients come to you first, what is the most distressing factor for them? Is it the fact that they're incontinent? Is it sexual function? Is it pain? Like, what actually brings them to you in the first place?
Yes, thank you very much for the question. No, first of all, in my hospital in Milan, we just opened since 1 year the pelvic unit, the outpatient clinic of urogynecological practice. So usually patients are coming to us with already specialized request, and most of the cases are prolapse. So the patient usually says that she has something that bothers her in between the legs. So the most common symptom is always often the prolapse itself, followed by the urinary function. So yeah, it's urinary incontinence or difficulty to void the bladder. But yes, I think that these two symptoms are the principal symptoms that we can find. Otherwise, usually during a routine visit, so outside from the urogynecological ambulatory, we can see maybe also other symptoms such as pain or bowel dysfunction. But unfortunately, the sexual function is something that it's not so frequently reported by patients. So yeah, it's something that we should investigate after.
I was wondering if it was any better in Italy than it would be in Ireland, because the Irish, I think, would be slower to go about the sexual function. I think they'd go about the pain, the prolapse, everything else first. I think sexual function comes second.
So this is why it's important to investigate, or also to help us with these questionnaires. I think it's something that we can do, such as health professionals, not only like doctors, but also nurses, and I think also outside from the hospital, maybe with our friends, it's important to talk about these topics.
Stefano, can I ask you then, just in relation to, have you used the hypopressive therapy yourself, or would you promote it? I mean, at the end of your talk, I kind of feel what you're saying to us is really pelvic floor muscle training is probably just as reliable as any of the others. And then, it's nice to see that there are new things coming online, and it's nice to know where they're coming from. But at the end of the day, are you just telling us just to continue with our pelvic floor muscle training?
Well, this is an interesting question. And just to summarize, on a general basis, I would say yes, because the pelvic floor muscle training have the strongest evidence behind it, years and years of clinical trials, guidelines, and everything in between. However, I've used hypopressive therapy successfully with a patient who has what the EAUN would call a difficult case. I mean that she was an elderly woman with 2 centimeters opening of the anus, after surgery for cancer, rectal cancer, and 30 cycles of radiotherapy. She was completely unable to perceive her pelvic floor contractions, even with electrical stimulation, digital stimulation, and whatever. and she was unable to correctly perform the exercises for strengthening the muscles, but she was very, very good at doing hypopressive therapy. The result was not a miracle, but it improved a little bit her condition because she could not undergo surgery, because this would have made her incontinent. She had this kind of opening of 2 centimeters, as I said before. So hypopressive therapy had its role, and it was helpful in this selected case. So as a general reply to your question, I would say on a general basis, in the absence of very specific cases, go for the pelvic floor muscle training. But on a specific, in a specific situation, do a thorough assessment of your patient and see what he or she is able to perform and what the best option can be.
Thank you. Interesting, I suppose, because every patient is an individual, and what suits one doesn't suit everybody. And then sometimes people really want the surgery and they want the quick fix. Yeah. I kind of look back at it and I think about it in relation to frequency volume charts. You know, when a patient comes to you and they're having a problem with incontinence and you ask them to fill out the frequency volume chart and you see them doing it in the waiting room, you know they're never going to do their exercises and they're never going to do anything. You can actually tell before they start. So it's a bit like that, you know, how committed are the patients to doing these exercises, and we need to bring them with us. So yes, I do agree.
I agree.
Yeah. I think I've one final. Has anybody else any more questions? Any questions come in to me? No, but just to let you know that there will be a recording of the webinar, which is available on the EAUN YouTube channel, and it'll be there in about 48 hours. You are entitled to get accreditation for it, and you get 1 CNE point, and you get that on the EAUN on your login on your website. I'm trying to think, is there any more questions or anybody else? No, I'd just like to say a huge thank you to our 3 speakers today. One talk was better than the next, and I enjoyed listening to you all. It was a pleasure to be here on behalf of the continence group of the EAUN, our SIG group. We're a small group and we work very well. We're delighted to share our experiences in that with you. So with that, Dr. Margherita Alfona, Stefano, and Dr. Giorgia Ghia, a special thanks to you all. And with that, I will close the meeting. Thank you.
Thank you. Thank you very much for attending. Goodbye.
Bye.